Today our topic of discussion will be testicular tumors. So as of earlier sessions, I will also go by question and answer. So a question can come as classify testicular tumors, discuss investigation necessary to plan the treatment for a suspected testicular tumor, what are the treatment options available. Now the WHO classification of testicular tumors according to the histopathology are as follow. First, it can be classified as germ cell tumors and non-germ cell tumors. In the germ cell tumors, there is seminoma and non-seminomatous tumors. Seminomas comprises 48% of germ cell tumors, and they can be subclassified as spermatocytic, classical, and anaplastic subtypes. Among the non-seminomatous germ cell tumors, there are teratomas, yolk sac tumors, choriocarcinoma, and mixed non-seminomatous germ cell tumors. Now, teratoma can be as differentiated or mature, intermediate, immature, and undifferentiated or malignant. There may be yolk sac tumor, choriocarcinoma, and mixed non-seminomatous germ cell tumor. And apart from that, there will be mixed germ cell tumors. Now, other tumors are epidermoid cyst, adenomatoid tumor, adenocarcinoma of the reti testis, carcinoid, lymphoma, and metastatic from another side. And lastly, sex cord stromal tumors, they are 10% malignant. They may be Leydig cell, Sartori cell, and mixed or unclassified. Tumorigenic model for germ cell tumors of the testis are normal spermatocyte gives rise to totipotent germ cell. They can either give to seminoma or embryonal carcinoma. From embryonal cells, there will be extraembryonal differentiation. They can follow trophoblastic pathway to give rise to choriocarcinoma or yolk sac pathway to give rise to yolk sac tumor. Otherwise, embryonal cells can go for intraembryonic differentiation and leading to teratoma. Investigations. Investigations are for confirmation of diagnosis as well as staging. So USG is a diagnosis for confirmation and scanning of the testis. It is a mandatory test in all suspected cases of testicular tumor. Tumor markers in confirmed cases, staging is an essential step in planning treatment. Blood is taken prior to orchidectomy to measure the level of tumor markers, which are raised in around 50% of cases. A rise in alpha fetoprotein is seen in around 50 to 70% of non-seminomatous germ cell tumors, and a rise in HCG is seen in 40 to 60% of non-seminomatous germ cell tumors and around 30% of seminomas. When raised, these markers are used to monitor the response to treatment. The mean serum half-lives of AFP and HCG are 5 to 7 days and 2 to 3 days respectively. And reassessment of the markers following orchidectomy can indicate whether all the tumor tissues can be removed or not. Now, incidence of elevated tumor markers by histologic type in testicular answer is as follows. Seminoma, mainly HCG is raised but no raise in AFP. Teratoma, both HCG and AFP are raised. In teratocarcinoma, both HCG and AFP are raised to very high percentages. In embryonal carcinoma, again, both HCG and AFP are raised. And in choriocarcinoma, 100% rise in HCG is there, but without any rise in AFP. Now, next step is X-ray and CT scan. A chest X-ray will occasionally demonstrate the classical cannonball metastasis. CT scan of chest and abdomen has taken over as the most useful means of detecting metastatic disease and for monitoring the response to therapy. So again, chest X-ray, routine chest X-ray detect 85 to 80% of pulmonary metastasis. CCT abdomen can detect retroperitoneal nodes. PET has no apparent advantage over CT, so with MRI. Now you can try to remember the TNM classification of tumor of testis. T stands for primary tumor, where TX where tumor cannot be assessed. T0, no evidence of primary tumor. TIS, intratubular cancer. T1, limited to testis and epididymis, no vascular invasion. T2, invades beyond tunic albuginea or has vascular invasion. T3, invades spermatic cord. T4, invades scrotum. Infraregional lymph nodes, NX cannot be assessed. N0, no regional lymph node metastasis. N1, lymph node metastasis less than equal to 2 cm or multiple nodes. None more than 2 cm and less than 6 nodes positive. N2, nodal mass more than 2 cm and equal to 6 nodes positive. N3 nodal mass more than 5 cm. M stands for distal metastasis. M0 no distal metastasis, M1 distal metastasis in non-regional lymph nodes or lungs, and M2 non-pulmonary visceral metastasis. Now there are serum tumor markers. S1 হচ্ছে lactic as S0 markers levels within normal limits. S1 lactic acid dehydrogenase LDH 1 less than 1.5 times normal and HCG less than 5000 ml MIU per ml and AFP less than 1000 nanogram per ml. In S2, LDH is 1.5 to 10 times normal or HCG 5000 to 50,000 MIU per ml or AFP 1000 to 10,000 nanogram per ml. S3 LDH more than 10 times normal, HCG more than 50,000 and AFP more than 10,000. So treatment, principle of treatment. Treatment should be aimed at one stage above the clinical stage. Seminomas are radiosensitive, stage 3 with radiotherapy. Non-seminomas are non-radio-resistant and best treated by surgery. Advanced disease or metastasis respond well to chemotherapy. First of all, you should go for radical inguinal orchiectomy for the first-line therapy. Lymphatic spread initially goes to retroperitoneal nodes. Early hematogenous spread rare. Bulky retroperitoneal tumors or metastatic tumors initially downstage with chemotherapy. Now treatment of seminoma, stage 1, 2A, 2B. Radical inguinal orchiectomy followed by radiotherapy or ipsilateral retroperitoneum and ipsilateral iliac group lymph nodes is given. Bulk is stage 2 and 3 seminomas. Radical inguinal orchiectomy is followed by chemotherapy. Treatment of non-seminomas, stage 1 and 2A, radical orchiectomy followed by retroperitoneal lymph nodes resection. Stage 2B, RPLND with possible adjuvant chemotherapy. Stage 2C and stage 3 disease, initial chemotherapy followed by surgery for residual disease. Now, standard chemotherapeutic agents for non-seminomatous germ cell tumors are bleomycin, etoposide, and cisplatin. The toxicity of bleomycin is pulmonary fibrosis, while etoposide has myelosuppression, alopecia, renal insufficiency, and secondary leukemia. Cisplatin can cause renal insufficiency, nausea, vomiting, and neuropathy. Now, next question is chemotherapy in testicular tumor. Chemotherapy in testicular tumor for stage 1 seminomas. Chemotherapy is an option that works as well as radiation is 1 or 2 cycles of chemotherapy with the drug carboplatin after surgery. Many experts prefer chemo over radiation because it seems to be easier to tolerate. Stage 2A seminomas, another option is chemotherapy with either 4 cycles of etoposide and cisplatin or 3 cycles of bleomycin, etoposide, and cisplatin. Your doctor will watch you closely to look for signs that the cancer has come back. Stage 2B seminomas, chemotherapy. This is the preferred treatment. You can get either 4 cycles of etoposide and cisplatin or 3 cycles of bleomycin, etoposide, and cisplatin. Stage C, 2C seminomas, chemotherapy with 4 cycles of etoposide or 3 or 4 cycles of bleomycin, etoposide, and cisplatin. Radiation therapy is generally not used for stage 2C seminoma. Now, stage 1A non-seminomas. Chemotherapy is given instead of surgery. Doctor may suggest to get 1 cycle of the BEP regimen. This helps reduce risk of relapse. Stage 1B, T2, T3, or T4 chemotherapy instead of surgery. Doctor may recommend 1 cycle of the BEP regimen. If cancer was found in lymph nodes after surgery, you may get 2 to 4 cycles of BEP or EP. Now for stage 1A non-seminoma. If tumor marker levels are still high even after the cancer has been removed, but the CT scan does not show a tumor, chemo is recommended. Patient may get either 3 cycles of BEP or 4 cycles of EP. Now stage 2A non-seminomas. If tumor markers levels are normal, chemotherapy. If cancer was found in many lymph nodes, give either 4 cycles of EP or 3 cycles of BEP. Stage 2B for stage 2B non-seminomas. If tumor marker levels are normal, chemotherapy. Give either 4 cycles of BB or 3 cycles of BEP may be used. Stage 3 seminomas and non-seminomas. Both stage 3 seminomas and non-seminomas are treated with radical inguinal orchiectomy followed by chemo with either 4 cycles of EP or 3 or 4 cycles of BEP. Patient may get 4 cycles of BEP if you have an intermediate poor risk non-seminoma. This depends on the spread to distant areas and tumor marker levels. If there is medical reasons that make treatment with bleomycin unsafe, then one may get VIP, that is vinblastine, ifosfamide, and cisplatin. If the cancer is seminoma that has spread to bones, liver, or brain, it is intermediate risk, then give VIP. If the patient has a high levels of tumor marker HCG, distant spread of cancer is seen on CANS, and there is a high suspicion that they might have a testicular carcinoma, chemo may be started without biopsy or surgery to remove the testicle. Now, another question can come as that 20-year-old male patient presenting with tight testicular mass, how will you proceed to investigate and manage the case? For all practical purpose, the patient most probably suffering from non-seminomatous germ cell tumor. Risk factors include a history of testicular cancer in the contralateral testis, cryptorchidism, gonadal dysgenesis, prenatal exposure to high estradiol levels, exposure to chemical carcinogens, trauma, and orchitis. Other risk factors may include childhood inguinal hernias and any cause of testicular atrophy. They tend to be more aggressive than seminomas and frequently metastasize. Clinical examination. Testicular cancer presents as a painless unilateral testicular scrotal mass as a casual US findings are revealed by a scrotal trauma. Scrotal pain may be the first symptom in 20% of cases. Gynecomastia appears in 70% of cases, more common in non-seminomatous tumors. Back and flank pain due to metastasis is present in about 11% of cases. Ultrasound must be performed in any doubtful case. A correct diagnosis must be established in all patients with an intrascrotal mass. Ultrasonography serves to confirm the presence of testicular mass and to explore the contralateral testis. Its sensitivity is almost 100% and it has an important role in determining whether a mass is intra or extra testicular. US of the testis should be performed in young men with retroperitoneal or visceral masses and or elevated serum human protein gonadotropin or alpha fetoprotein and are consulting for fertility problems and without a palpable testicular mass. CCT abdomen thorax to know the origin and extension can be done. MRI of scrotum offer high sensitivity and specificity than US in the diagnosis of testicular cancer, but its high cost does not justify its routine use for diagnosis. Again, the serological markers are as follows, what we have already discussed. Now, management of non-seminomatous germ cell tumors. Following radical orchiectomy and formal staging, the patient is normally managed by retroperitoneal lymph node dissection in selected cases. In the presence of elevated AFP, a seminoma would be managed as for teratoma. Combination chemotherapy introduced in the 1980s revolutionized the treatment of metastatic testicular teratoma, which was hitherto virtually untreatable. Now, treatment and follow-up for non-metastatic disease in T1 to 4 N0 M0 A0 surveillance or chemotherapy with bleomycin, low-dose etoposide, and cisplatin for 2 cycles, depending on risk factors for relapse, lymphatic or vascular invasion T2 to T4. Surveillance in presence of risk factors resulting in 25% of relapse rate most less than 1 year post orchidectomy. Now, metastatic disease, if the patient has good prognosis, chemotherapy, bleomycin, cisplatin, 3 cycles with RPLND for residual or recurrent mass, salvage chemotherapy histology confirms tumor. Intermediate and poor prognosis, chemotherapy with bleomycin, etoposide, and cisplatin of 4 cycles, RPLND for residual or recurrent disease, salvage chemotherapy if histology confirms tumor. Approximately 70% of NSGCTs produce hormonal markers. Alpha fetoprotein typically elevated in York-Sac tumor, beta HCG typically in choriocarcinoma, and lactate dehydrogenase in almost all cases. Now, pathology. Non-seminomatous germ cell tumors can be divided histologically into embryonal cell carcinoma, choriocarcinoma rare but have worse prognosis, York-Sac tumor, and teratoma, which accounts for 5 to 10% of germ cell tumors. They are mature, immature, and malignant. Mixed germ cell tumor is the most common type of non-seminomatous germ cell tumor, accounts for 40% of all germ cell tumors. The most common combination is teratoma and embryonal cell carcinoma. Treatment and prognosis. The prognosis of non-seminomatous germ cell tumors is variable and depends on the biological behavior of the individual tumor. Prognosis can be inferred from tumor markers, the location of the primary tumor, and of course, presence of metastasis. Good prognosis are tumor markers alpha fetoprotein less than 1000, beta HCG less than 5000, and LDH 1.5 times lesser than upper limit of normal. Non-mediastinal location of the primary tumor and no non-pulmonary metastasis. These patients are usually treated with orchidectomy followed by chemotherapy. Now, intermediate prognosis, tumor markers as already told, non-mediastinal location of the primary tumor, no non-pulmonary metastasis. These patients are started with chemotherapy cycles and sometimes followed by adjuvant surgery. Poor prognosis, tumor markers with alpha fetoprotein more than 10,000 nanogram per ml, beta HCG more than 50,000, LDH more than 10 times upper limit of normal, mediastinal primary tumor, non-pulmonary metastasis present. So this conclude the topic on testicular tumor. So these are the questions you may face in the exam and you have to answer like that.